They concluded that the risk of epidural and spinal anesthesia in children undergoing cardiac surgery include undesired effects like nausea, vomiting, pruritus, hypotension, respiratory depression, and epidural hematoma formation. The incidence of these side effects do not appear to exceed that associated with intravenous opioid analgesia, and therefore they recommended the use of a regional technique. And we were able to, in the earlier on cases, we were able to extubate them early. That would mean that we were, ventilating them for about 3-4 days, and then we got it down to the next morning. And this child was extubated the next morning. And we assessed the pain score in our study, and we found that patients who were given an epidural block were definitely better off. But it's not only about early extubation. Now you have a patient where you can't close the chest, and you have to keep on ventilating him, and there's ongoing stress response. So to obtain that, you have the continuous infusion of an epidural, which will prevent the inflammatory response and the noxious stimulus from adversely affecting the baby. This child is again who has received an epidural and had stayed on the ventilator for about 7-8 days, and then was extubated. But here again the same protocol was used. So this is not fast track. Here I'm just trying to highlight that the patient can be using the same protocol, can be sedated, be kept pain-free and on ventilator, and can be relatively awake. Now, pulmonary hypertensive crisis with better control of stress response, optimum analgesia and sedation, you can achieve early extubation. In Military Hospital Cardiothoracic Center in 2014 and 15, we managed to extubate 40 patients on table, and then I moved on to another hospital and used the same protocol there. I'll present that data too. So we do a pre-op optimization of the patient. Normal coagulation profile is established, and we gave a vitamin K dose and universal protocol for fasting status for pediatric patients. The pre-medication which I use is oral triclofos, 50 milligrams per kg, 45 minutes prior to shifting from the ward to the operating room. And in the operating room, an intranasal ketamine, 7 milligrams per kg, and midazolam, 0.4 milligrams per kg is administered 15 minutes prior to induction. And then the baby is separated from the mother, where the patient is generally induced with 2 milligrams per kg of IV ketamine, supplemented with 1 to 2 micrograms per kg of intravenous fentanyl. And then after intubation, the epidural catheter is inserted in the T4-5 interspace, and using a 24 gauge epidural catheter. The neuraxial block forms the mainstay of the protocol, and every baby, irrespective of the weight, receives an epidural catheter. And the only contraindications are spinal deformity or coagulopathy or a post-op anticoagulation is expected with more than 2 drugs. That's the protocol which we use, 0.25% bupivacaine, 0.5 ml per kg with 50 micrograms per kg of morphine. Second bolus of 0.25% bupivacaine just before sternotomy, and we maintain an infusion with 0.125% bupivacaine at the rate of 0.1 ml per kg per hour for 24 to 48 hours. In neonates, the dilution is increased that we give 0.125% bolus and only 30 micrograms per kg of morphine, and 0.3 to 0.5 ml per kg is repeated after 40 minutes intra, and then a continuous infusion till the baby is weaned off ventilatory support. This is a short video clip showing the placement of the epidural catheter. This is in the T4-5 interspace, and you place the catheter, and then I also make a subcutaneous tunnel so that it remains stable, and the first bolus is injected at the just after placing the catheter. Intra-op hemodynamics and inotropes give intra-op IV fluid management, with bringalactate and 5% dextrose with some additives like magnesium, calcium, and methylprednisolone, tranexamic acid. And you maintain an optimal hematocrit. Elective early low dose inotropes are started upfront, and the temperature patient is kept on warming systems with an intravenous inline fluid warming. You keep a close watch on glycemic control, and in patients with pulmonary hypertension we use a sildenafil infusion. We give a preoperative methylprednisolone in neonates 12 hours before one dose and one dose 1 hour before induction, and in older children we give only 30 milligrams per kg at the time of induction. And we limit the extracorporeal circuit and volume, maintain optimal perfusion pressure, moderate hypothermia, and babies rewarm to 35 degrees. And the warming is continued after CPP with the inline fluid warming and the warming mattress, and the patient's temperature is always at 37 degrees by the time we are shifting them. Careful choice of myocardial preservation techniques, ultrafiltration with slow continuous ultrafiltration and modified ultrafiltration after separation from cardiopulmonary bypass. We use pH stat in where we have gone down to less than 32 degrees during bypass, and we monitor cerebral perfusion with near-infrared spectroscopy. Meticulous control of hemostasis, antifibrinolytic. Not part of the low dose vasopressin right in the beginning, which helps maintain the hemodynamics much better. And by the time the baby is being shifted to the ICU, the vasopressin is already tapered off. And in severe pulmonary hypertension, we use a loading dose of intravenous sildenafil at 0.4 milligrams per kg after removal of cross clamp, and then continuous infusion of 1.6 milligrams per kg over 24 hours. Now, the patient should be hemodynamically stable with minimal inotropic support, adequate hemostasis, adequately rewarmed, cardiopulmonary bypass less than 150 minutes, and an epicardial echo which shows good repair. Intraoperatively, after bypass, I put them on an SIMV mode with pressure control and put a very sensitive trigger, and do not repeat a muscle relaxant. So the weaning from ventilation starts off immediately after coming off bypass, while the ultrafiltration is going on and hemostasis is being secured, and quite often the baby is extubated while the skin is being closed. Post-operatively, we use high flow nasal oxygen therapy with this Fisher and Paykel unit called Airvo. And we give 2.5 to 3 liters per kg per minute of this 60% FiO2 humidified air, which is reduced to 2 liters per kg per minute, and FiO2 40% after 4 hours, and then gradually the patient is weaned off this over the next 24 to 48 hours. So we have done 331 patients between August 2015 and July 2016. 250 were extubated on table. 81 were not extubated, and this is the data of all the spectrum of cases that we did who were extubated. Tetralogy with no transannular patch, out of 49, all of them were extubated. With the transannular patch, 10 got extubated. Like that, Fontaine and bidirectional Glenn, all patients get extubated on table. Then this TOF with absent pulmonary valve, 2 of them were extubated on table. AV canals, transitional, all were extubated, but the complete AV canal, we have not extubated them on table. Ross, aortic valve replacement, mitral valve repair, they all perform well with early extubation. This is just the statistics of that paper which was presented in the World Congress. This is a picture of the baby who was TAPVC extubated on table. You can see now here that is the epidural infusion. This is the high flow nasal oxygen, and the baby is receiving minimal inotropes. and 2 drains. This is just immediately after the baby was shifted from the operating room. We have re-intubated 6 patients. 2 cases were re-explored for bleeding and were extubated on table after the surgery, again after the re-exploration. And 2 cases, there were recent pneumonia and there was a mucus plug. So he had to be re-intubated and then extubated in the next 12 hours. 1 case of tetralogy repair developed junctional ectopic tachycardia and low cardiac output syndrome and had to be on ventilator for much longer after that. 1 case was post bidirectional Glenn, re-intubated after 36 hours with stridor, tracheobronchomalacia, and then a tracheostomy and prolonged hospital stay. So it's safe in select patient groups, combined decision between surgeon, anesthetist, and the intensivist, lower age, weight, and higher inotrope score, and the statistical category are significant factors which preclude extubation. The message is that regional anesthesia for pediatric cardiac surgery has come of age, and benefits far outweigh the risks and renders a versatile approach to perioperative management of patients with compromised myocardial function, unsurpassed analgesia in the perioperative period, and on-table extubation is no longer a myth. So if you align, this is what I call the reverse Swiss cheese. If all the holes are properly aligned, you will get a favorable outcome. The future is to study whether the epidural or regional anesthesia, it really improves the cardiac output, and you can measure the organ perfusion with near-infrared spectroscopy and targeted measurement of renal function and evaluation of gut wall integrity and function. I have been starting alimentation in these children in 2 hours after the surgery, and they tolerated it well. Thank you.